I will be discussing frontline therapy of patients who are not eligible for transplantation. And we'll be looking at the two main regimens we use, VRD and DARA-RD, and basically try to see which regimen should we use, when do we use these regimens. Let me share my screen. I have no conflicts of interest to disclose. So before we start, I think it's important to just quickly look at the data with these two regimens using the two big randomized trials. The SWOG trial, which looked at VRD versus RD, bortezomib Lendex versus Lendex. And in this trial, just the main point to keep in mind, it's not really VRD versus RD. It is VRD for 6 months, followed by RD in one arm, and RD in the other arm. So the triplet was given only for 6 months. The main results of the trial are, number one, the progression-free survival with VRD was longer at about 43 months versus 30 months. The overall survival was also longer with VRD compared to RD. As a result of this trial, VRD became a standard of care in the US and in many other countries. It's very easy to use regimen. Even though the trial used it twice a week, we usually use bortezomib once a week subcutaneously, well tolerated. We know a lot about this regimen. The second regimen is DARA-RD. DARA-RD was studied in the MAYA trial. In this trial, DARA-RD was compared to RD, very similar to the SWOG trial. But the main thing is that this was a true triplet versus doublet. Here, DARA-RD is given the whole way through as a triplet, whereas the control arm is a doublet. So that's different between the VRD trial, where the VRD triplet was only given for 6 months. In this trial, the subsequent analysis shows very similar to the SWOG trial that overall survival was also prolonged with DARA-RD compared to RD. So we have these two regimens, both are showing excellent results in transplant ineligible or transplant deferred population. And now the question is, how do we compare the two? The first thing is efficacy. How do these two stack up when you look at efficacy? Now, it'll be nice if we had a randomized head-to-head trial of VRD versus DARA-RD. And because that trial has not been done and it's not going on, we don't have those results. So we are going to have to compare between two trials. And that's really hard because the trials are different. The SWOG trial included patients who were younger than 65 who deferred transplant. And so only about 39 or 40% of patients in the SWOG trial were over the age of 65, whereas MAYA trial was basically done in people over 65. So keep that in mind when we try to compare the two trials. When you look at progression-free survival, you can see here that the DARA-RD regimen gives a significantly longer progression-free survival compared to VRD. Even though there's no statistics done, you can see it. It's more than 65 months with DARA-RD compared to 41 months with VRD. And that's 41 months with VRD, even though VRD is a younger population. But can we really compare the two like that when you know that the triplet was given only for 6 months with VRD and the triplet was given for 5 or 6 years with DARA-RD? So could it be just the extra drug given for a longer period of time? When you look at overall survival, the 5-year overall survival rates are basically identical between the two groups, 69% versus 66%. And the medians are very long. Of course, there's a longer follow-up with VRD. So these regimens give about the same overall survival. But as I told you, the VRD trial patients were younger. So what happens if you look only at the older population? Here I'm looking at only at the patients over the age of 65 in the VRD SWOG trial compared to the DARA-RD. And you can see here that the medians are somewhat similar. This is the yellow line, that's VRD patients who are over the age of 65. The 5-year overall survival rate, though, was somewhat longer for DARA-RD, 66% 5-year overall survival, 55% overall survival for VRD. But again, can you conclude that DARA-RD is more effective? The main reasons why you cannot conclude that is, number one, with VRD, the triplet was used only for 6 months, followed by the doublet. whereas in DERA-RD, you're committing the patients to triplet for several years. That might account for differences in the progression-free survival. But in terms of overall survival, if DERA-RD giving the triplet for 5 years gives you better overall survival, then wouldn't that be the better way to do it? Not exactly. The SWOG trial and the MAIA trial were done at totally different time periods. The SWOG trial overall survival rate of 55% for the age over 65 reflects the fact that it was done between 2008 to 2012. Many patients would not have had salvage therapy accessible, salvage with daratumumab or elotuzumab or several other things, whereas the MAIA trial accrued between 2015 and 2017, where a lot more salvage treatments were available. So that 10% difference in overall survival that you're seeing at 5 years could be really explained not just the difference between the two regimens, but based on access to salvage therapies being much, much more available for MAIA trial patients than for the SWOG trial patients. What about toxicity? Toxicity is an important factor to compare between the two, but it's very hard. One is an industry trial where monitors go in and check on all of the toxicities month after month. The other is a cooperative group trial, the SWOG trial, where there's only auditing and there's no regular monitoring, so it's hard to compare the toxicity. But one thing we know is that with bortezomib, you're going to have a higher risk of neuropathy. But with daratumumab, particularly when you're giving daratumumab month after month for many years, you're going to increase the risk of infections. And we don't know how these two compare long term. After all, overall survival just does not depend on only controlling the myeloma. If you control the myeloma, but the infection risk is higher, that will also compromise survival. So keep that in mind. We also know that during COVID, patients with prolonged daratumumab therapy had problems with mounting antibody response, and we need to keep these things in mind. But the main problem is we cannot really compare the toxicities head to head, and even the bortezomib dosing being changed to once weekly sub-Q makes a neuropathy risk lower. The third thing is cost. Cost is an important consideration. Bortezomib has now become generic, and as a result, it's actually one of the most affordable medications now in the US. Bortezomib generic sub-Q is only about $10,000 annual cost for the whole year, whereas all of our other drugs are much more expensive. As a result, if you look at the approximate annual cost of VRD in the US, it's mainly driven by the cost of lenalidomide at $224,000 versus DARA-RD, which is more expensive. If you look in Europe, where lenalidomide is generic, bortezomib generic, if your countries spent newly diagnosed myeloma patients, the dollars you spent on VRD, that's only about $10,000 a year, whereas you would spend upwards of $100,000 a year with DARA-RD. Now, those things need to be considered when you eventually decide on one regimen versus the other. Bottom line is that it's hard to choose between the two regimens. You have to take into account the patient in front of you. You have to take into account whether they have an increased risk of infection as the main problem or neuropathy risk. You have to take into account cost, access, affordability when you decide. The efficacy seems to be similar between both regimens. So my algorithm here is pretty straightforward. For standard risk patients, I think either one is okay. Personally, I prefer VRD because I think it's about the same efficacy, much less expense, and only 6 months of a triplet, after which patients just take lenalidomide. So makes it a very convenient regimen. If you were to choose DARA-RD, that's okay as well. Very good regimen, gives extremely good results, but you have to understand that it carries the risk of infection and it's much more expensive. For high-risk patients, however, you could use DARA-RD, but I prefer VRD for one reason. We are tending to use both bortezomib and lenalidomide in combination, a PI-IMiD combination as the maintenance. And therefore, for high-risk patients, rather than start with DARA-RD and then switch to bortezomib, I'd rather just use VRD for about 6 months and then use bortezomib plus lenalidomide maintenance. In the future, we have to look at myeloma more like people look at lymphomas. each disease, each cytogenetic abnormality is almost like a unique disease. And therefore, we may have to fine tune our treatments based on whether the patient has a 414 myeloma or a 1416 myeloma or 1114 myeloma or a hyperdiploid myeloma, and whether it's double hit or triple hit. If these patients have more risk factors, we may even use more aggressive regimens.